Thank you all. I wish I could be present and talking to you about this important topic. Today, I will talk about diaphragm pacing and how we can use it to decrease mechanical ventilation and improve diaphragm function. In full disclosure, what I'm talking about was invented at my university. I was one of the ones that helped develop this technology. The problem really is the increasing ventilator research burden and morbidity. We all know COVID-19 pandemic highlighted this. In the United States, 100,000 tracheostomies are done for failure to wean. But we do know that 40% of the time a patient is on a mechanical ventilation, it's after that acute event, and we're addressing ventilator-induced diaphragm dysfunction. We all know that 50% of diaphragm atrophy occurs in 24 hours. I'm going to talk today about how diaphragm pacing can decrease mechanical ventilation and help many patients. I've been working at this for 25 years. I have multiple animal models. I've done 25 years of research on this. Through all of our development, we spent millions of dollars developing this technology and studying patients. Over 2,000 patients have been implanted in 34 countries. It has been implanted in Brazil. I've done over 700 patients. In the last 2 years, we've implanted over 200 patients. Interestingly, over 10 million breaths per day are provided with this technology worldwide. So we know this works in helping patients breathe. I'm going to really talk about the two systems. There's this chronic system that can be utilized from 30 days to 20 years. We use it for spinal cord injured patients, phrenic nerve injuries, and a lot of other rare diseases. And then a temporary diaphragm pacing, which we use for acute weaning from mechanical ventilation. I'll discuss with you some of our results in these areas. Again, what you're going to see on this video here is how we're looking at the right diaphragm. As you can see in this right diaphragm, nothing's happening. This is how we laparoscopically use our chronic system. And again, we're going to check on the other diaphragm, and you'll see very rapidly on how quickly we can tell. Again, that's a gastrostomy tube. And here on the left diaphragm, beautiful contraction. This is a patient who's been on a ventilator for many years. We can get patients off the ventilator with spinal cord injury. We then implant 2 electrodes on each diaphragm. It's a fairly simple implantation technique, laparoscopically. I'll show you our newer technology where we can place it during open surgery. Again, once we place the electrodes, anterior diaphragm contracting, posterior diaphragm contracting. Fairly simple concept to help you breathe by implanting these electrodes. And then for our chronic system, it's a percutaneous device, and we program this device to give a nice breath for each area, or if we're getting recovery from an injured phrenic nerve. It's fairly straightforward, percutaneous way to set this. It's almost like setting your ventilator for these patients. Now I'm going to kind of show you during an open heart operation a kind of diagram of putting in this electrode. We all know that we place temporary cardiac electrodes in many patients during open heart surgery. This is a fairly simple concept of placing electrodes into the diaphragm muscle. Again, this could be done through the chest, through the abdomen. It can be done thoracoscopically, laparoscopically, or as we're showing here, open. All we're doing is placing the electrode near the phrenic nerve in the diaphragm so we don't risk injuring that phrenic nerve. We then bring 2 electrodes out on each side. Just the Keith needle, fairly standard if you've done any cardiac surgery. It's a straightforward aspect. What I like to say is having these electrodes in a high-risk patient, it's many times like having a chest tube in just in case, or Jackson Pratt just in case there's a problem. Now I'm going to talk about our results. As you can imagine, over 25 years, I have many stuff I can talk about. I'm going to talk briefly about spinal cord injury. We'll review our results in diaphragm dysfunction, unilateral, and then outline some of our results that I'm happy to share with you about our acute ventilator weaning. And again, I can't neglect to say that the second patient ever implanted was Superman Christopher Reeve, who had a spinal cord injury. We could get him off the ventilator fairly straightforward. We know in spinal cord injury, it's a devastating injury, and many of these patients will be on the ventilator for quite a prolonged period of time. We can get them off by adding this area of diaphragm pacing. Here's just some of our most recent results. In 2020, we showed that diaphragm pacing can go from 30 days in the ICU to 10 days. That's a drastic improvement in these patients, getting them off the ventilator, out of the ICU when there's a shortage of ICU beds. Another study showed the cost savings in US dollars per patient because we decrease that hospitalization. We can save about $150,000 per patient. So that's a significant savings for these patients. The data in spinal cord injury was so impressive that the American College of Surgeons made it in their best practice guidelines for trauma centers that we recommend everybody in spinal cord injury in this publication that came out in March of 2022 should be offered this technology to get off the ventilator. I'm going to talk a little bit about unilateral diaphragm dysfunction. I began looking at this in the 2010s and 2014 was my initial publication showing that 86% of the patients, we get recovery of that diaphragm, which is important. We had some tracheostomy, ventilator-dependent patients that actually had diaphragm dysfunction because of a phrenic nerve injury, so they couldn't move their diaphragm. Diaphragm pacing allows that diaphragm and nerve to recover to get people off the ventilator. I then presented at the American Thoracic Society meeting in 2020, a much larger group of 62 patients. And again, we had about 70% complete recovery. And this is an important thing. And I'll show you on some pictures here. Extremely elevated diaphragm. Historically, you'd say we should do a plication on this patient. But we got complete recovery. So you can see that diaphragm recovery. This is a patient that had that elevated diaphragm for 2 years. We added diaphragm pacing, complete recovery of the diaphragm. We can read the diaphragm electrodes, as you can see here. The right and left diaphragm EMG recovered. Again, another example of extremely elevated right diaphragm. Again, this is a patient who actually had Parsons Turner, just idiopathic, and she's extremely overweight. So we did a simultaneous bariatric operation and diaphragm pacing. So not only weight loss, but complete recovery of that diaphragm, as seen by chest x-ray, fluoroscopy, and diaphragm EMG analysis. So nowadays in our facility, if we see an elevated diaphragm, before we start thinking of plication, we at least give this a 70% chance of complete recovery, then we pull the electrodes. So it's physical therapy for that diaphragm. And why is diaphragm pacing so important? We've shown since this 2008 New England Journal of Medicine article on how rapidly that diaphragm atrophies, how rapidly things will change. And so we need to try to address that because you'll get 50% atrophy, very rapid conversion of type 2B muscle fiber. That led us to look at other groups of patients. We know after open heart surgery, about 12% of patients will be on mechanical ventilation after 24 hours. Because we're doing sicker patients with open heart, 4 may require mechanical ventilation after 5 days. That leads to all these other problems. So we started looking at this. So we did our initial pilot cardiac trial that showed, and we presented this at the STS meeting in 2021, that one, we could place these temporary diaphragm pacing electrodes, a trans-air system. It's feasible, it's safe, we can improve diaphragm function, and utilizing this significantly increased extubation by 48 hours. So we did an ad hoc comparison. This, again, a small group of patients, 5 out of 6, we extubated by 48 hours. These were all patients on a ventilator at 24 hours. Only 1 out of 4 that we weren't pacing got off the ventilator by 48 hours. So that's within starting at 24 hours. That led us to start looking at what else we could do. And I'm actually presenting it this week in Denver at the Society of Thoracic Surgeons meetings, the STS perioperative meeting. And I had 21 patients that we implanted at the time of high-risk cardiac patients with an elevated diaphragm preoperatively, and 90% of those patients we extubated in less than 24 hours. 67 we extubated in less than 12 hours. And again, we looked at patients with this unilateral, 93% we rapidly extubated. So we actually had a great knowledge of what we could do on these patients. We can reverse the atrophy. We can help prevent VIDD if you would have been on a ventilator for a while. Then we looked at a thoracoabdominal, major operation. We cut the diaphragm off the rib cage. We know that diaphragm is going to be stunned for a while. We had 7 patients, and again, infected aneurysm, major operation. We put the electrodes in. We then have a percutaneous system. We stimulate that diaphragm to prevent the problem. We can actually show by stimulating immediately, we had all patients extubated. We presented this in 2021, and we've actually probably doubled the patients in our thoracoabdominal patients that we've done this in. Again, high-risk patient, simple, put these electrodes in. We can help maintain everything. And this is actually our lung transplant area that we looked at. And this is actually, I presented this at the International Society of Heart and Lung Transplant. All of our lung transplant patients, we now know, again, there's been other publications showing in these high-risk thoracic procedures that you can injure the phrenic nerve. We know if we study them prospectively, about 40 to 60% of patients will have diaphragm dysfunction because of an injured nerve during that operation. We showed that we could put these electrodes in during this operation. We could stimulate the diaphragm. We can analyze if there's an injured phrenic nerve, and we can promote recovery if there is a phrenic nerve, because of all of our other data showed that we could do that. So we showed that early diaphragm pacing can prevent ventilator-induced diaphragm dysfunction, help that nerve recover, And really, our experience is really for lung transplant in these high-risk patients, we should really offer this for all of our patients. These temporary electrodes, patients have no problems, you pull the electrodes. Patient has a problem, you can stimulate them. So kind of in this brief time period, I know I covered a lot of ground here, but in conclusion, all spinal cord injured patients should have implantation of this device. Patients with unilateral diaphragm dysfunction, and you see this a lot in your practice, we now offer diaphragm pacing before we do diaphragm plication. Complete recovery of diaphragm, then pull the electrodes is better than application. We now look at high-risk patients, those patients you're doing emergency surgery on. You add the temporary transaorus patients, electrodes in at the time of that operation. You now control the diaphragm. Patient has a problem, you start stimulating the diaphragm. Prevent ventilator-induced diaphragm dysfunction. Another option is for patients before you consider tracheostomy. Could we drive this ventilation? Could we prevent a tracheostomy in that long-term vent area? So these are all things, it's an exciting area to be in. Again, thank you for allowing me to be here. Again, simple stimulation causes the diaphragm to move. And again, after doing this for 25 years of research, nobody wants to be on a ventilator, and everybody chooses diaphragm pacing over everything else. I look forward to seeing you again in person sometime. And again, thanks for allowing me to be here. And it's great to be involved with everybody.